Okay, I'm continuing to the clinical study protocol, and I think this is the part that needs a little bit of interactive discussion rather than saving all the questions to the end, because I would actually encourage all of you to stimulate this study protocol, to challenge it. We are actually planning even to revise the protocol with currently minor revisions, but there is room for some improvement if you feel we should streamline some criteria in inclusion and exclusion or in the study procedures. The objective of this first clinical trial is a clinical endpoint trial. It's a first-in-human trial, first of all, so it's safety. But of course, we want to have the proof of concept. And in that proof of concept study, we have put in different doses of the drug. So it's a dose-finding study. So we are actually really completing in a first clinical study 3 main objectives of clinical development. It's a first safety, it's a proof of concept, and it's a dose finding. This is why the protocol looks a little bit complex in a 2-stage approach, but we felt it's actually possible and feasible to merge all these objectives into one. The second is, of course, to generate more additional endpoints that we want to apply probably in our confirmatory trial. And before I continue to the design, I think it is also important for you to understand the entire development of APO2 for diabetic foot ulcers is that this is the trial where we want to answer 3 main objectives. But with the next trial, we want actually to confirm that APO2 is efficient in diabetic foot ulcers for gaining sufficient evidence for the approval process. So there are 2 main clinical trials. We are currently not planning more than 2 clinical trials, and this is why these clinical trials should be performed thoroughly and with a good protocol. So I went through the main objectives, and now we come to the study design. What you see in this study design here is actually what we have been recommended by the FDA to include into a chronic wound study. Second, there are several guidelines, like from the European Wound Association. There are guidelines written recently, even in the Lancet paper, how to perform a clinical trial in wound studies. Because there have been many studies performed in chronic wounds where there is a doubt on the design, so there are clear recommendations what to be included. Further, we have introduced the design to the AGAS and also to PI, and both of them had no objections to what we are proposing here. So what you see in the first step, what we call safety lead-in, it's actually the first-in-men trial. The first-in-men trial has the main objectives of the safety, and this is why we are selecting a small patient cohort with a selected site, so we know that you are having very short communication ways to communicate to us wherever there is a safety issue. These first objectives is really just to prove that we can continue in a larger cohort. There is safe. We are not putting any patient on harm with treating them with APO2. The safety lead-in study is using 1 APO treatment arm. This is actually the middle dose compared to placebo. It's a 3-to-1 randomization, meaning that 9 patients are being treated with APO2 and 3 patients are being treated with our placebo. So, of course, this part is eminent to ensure that it is performed thoroughly. This is why we have now an investigator meeting. And during the site initiation visit, of course, we want your entire team to be trained on the protocol as deeply as possible. Because after the end of treatment period, the data will go to the DSMB. Professor Trautinger being one member of the Data Safety Monitoring Board. We have 1 diabetologist, it's Professor Prager. We have another dermatologist from Germany, it's Professor Augustin, who's actually one of the main names on many guidelines. And there is a statistician in the Data Safety Monitoring Board. What does the Safety Monitoring Board decide? They will look on the safety data, see that we have not put any harm to the patients, and this is the only objective. So if there is a safety issue that wounds are deteriorating, probably the DSMB will raise, okay, the data are not actually very consistent. We cannot decide further. They even can come back and say, we want to include more patients in the safety part. On the other hand, if they don't see any objections, any safety issue, they will give the go. There is no decision based on efficacy. So there is no decision to say, okay, we cannot see that the wounds are being healed, so stop it or continue. So no decision on this efficacy can be made by the DSMB. It's the only objective is on safety. So the DSMB report will go actually to the ethics committee, but also the AGES requested to have the DSMB report being reviewed before we can continue to further 16 sites across 4 countries, in Austria, Germany, Poland, and Czech Republic, to continue the entire study. So the 16 sites are a mixture of tertiary clinics like yours, but also we have a lot of secondary care clinics who are specialized in wound management. Especially, I think, in Czech Republic, we have predominantly secondary care clinics. So the going to the main study needs a lot of preparation. That is already being started in parallel. We are applying to the ethics committees in other countries and also the regulatory bodies in parallel to the performance of the safety lead-in study. For the main study, we have actually almost the same design. We are treating our patients in the same way, not making that one group is getting half of a treatment and the other group get the full treatment. So all our patients are being treated with the same design. That means they are being screened. After a screening, we have a 14 days observation period, and this is a minimum must. And this 14 days observation period is actually to ensure that the wound is not getting actually healed by itself. So the wound closure is not given by itself, so we cannot objectify what is our add-on to the wound closure. If after the run-in period of a minimum 14 days, the wound still fulfills the inclusion criteria, they can be randomized. And after that, the randomization goes into 4 groups. Patient can be treated with one of the 3 doses of APO2 or placebo. And this is a parallel arm, so we are not dose escalating. Patients can actually be randomly assigned to any of the 4 groups in parallel. The treatment period is 4 weeks. And of course, I understand this is a very intense period because patients need to come back to the clinics 3 times per week with at least 1 day apart. And during that period is to ensure that the wound dressing is being changed and the IMP is being applied every time they come to your clinic. This is a very intense period. You would think, why 4 weeks? The 4 weeks period is first of all generated out of the data that we have from the use of APO2 on the named basis, the pictures that Professor Ankersmit presented previously. There are a lot of evidence also from our preclinical experimental data that this time could be sufficient. And also, if you have seen on the data from Professor Holzinger, who actually applied the mononucleosares, the 4 weeks were quite a good, sharp marker. So the 4 weeks treatment has been taken for several reasons. But again, this study will show us, is 4 weeks sufficient, or should we have extended it to an 8 weeks treatment or longer? This is, as we said, it's a proof of concept, and it's also the dose finding. So the duration might be changed after this, might be even shorter. If you see that the wounds are getting closer far earlier, then we don't need to apply for a 4 weeks treatment. And this is probably for this study the main visit, the most important visit. It's the end of the treatment visit. After the first, after the first month of treatment, the end of treatment visit will be where we generate the primary endpoint. And this is the wound closure, actually, the percentage of the wound reduction at the end of treatment visit. Now you can see that we have a further 8 weeks follow-up. And the follow-up of diabetic wounds is very important because we want to see if you stop the treatment, what happens to the wound. Maybe our effect is sustainable, that it still promotes closure, or actually it breaks up. As soon as we stop the therapy, it breaks up. So the observation period after these treatment arm is eminent for us to understand what happens actually further, and also how we should design the next study in terms of the follow-up period. Who are the patients that we want to include in this study? We have many inclusion criteria, and this is why we have also a complex patient cohort in this study. The complexity is driven, first of all, they are diabetic patients, and we have actually put the age quite high. On the other hand, we have added in quite restrictive inclusion and exclusion criteria. And there is one exclusion criteria that actually gives you, as principal investigators, a lot of room for your judgment who is really, best suitable for this study. So they should be diabetic patients, and the HbA1c, and we had several discussions, is set fairly high. It is allowed up to 12%. Why? Because the main studies, epidemiology studies, diabetic foot ulcers, is in patients with average 10 to 14 HbA1c. There is no data proven that if you optimize the glycemic metabolism, that the wound gets closed faster. On the other hand, if we put the HbA1c far lower, then we wouldn't find our patients. So this is why we have given here a room to find the right patients for this study. The diabetic foot ulcer should be present at least 4 weeks or longer. So this goes to the definition of a chronic wound, actually. So the 4 weeks is giving the current standard of care time to see if they are successful for the wound closure. We have heard about the Wagner or the Armstrong classification. I go further in my next slide. What we want is a non-infected wound, and actually a wound that is not based on any ischemia. So this is the classifications of Wagner grade 1 and 2, or Armstrong 1A, 2A. Why we added those both is some clinics work more with the Wagner, some others with the Armstrong. Armstrong actually specifies the infection and ischemia specifically. The wound size is fairly a small wound, so we have seen where half of the food is actually showing wound ulcer. So 1 square centimeter to 8 square centimeters is fairly small. The restriction is also based on our development in the preclinicals, that we want to start with this wound size. If you go further to bigger, it will show after this study. So the wound size at time when I randomize even a patient should be more than 1 centimeter. So at screening, it might be 1 square centimeter, and I give them a 14 days of follow-up period. If the wound has been, reduced to less than 1 square centimeters, they are not allowed for randomization. There is a possibility that a patient has several wounds on their foot. So what we take is actually the largest wound, but as far as it's still fitting into these inclusion criteria as an index wound. The next thing is that we talked about the observation period. During this 14 days period, the wound should not change more than 30% between the screening visit and the randomization visit. And the further is what we've talked about, the arterial perfusion, that has to be given. So we understand that not all clinics have these facilities. It is possible that we take the results from the previous 6 months, but we need to have results or from the ankle brachial index, or from the toe pressure, or from the transcutaneous oxygen pressure. So there are several outpatient clinics that just use the toe pressure. It is okay even to use the toe pressure on the infected wound, of course. Some clinics have also the transcutaneous oxygen pressure measurement, but I think the ABI is the one that is most spread in the tertiary clinics, probably. And patients need to adhere to the offloading. We've heard about the Charcot deformity. If there is a deformity that we cannot put on offloading, those patients with those wounds are probably not suitable for this study. Okay, so just wanted to indicate it's or toe pressure. So there are different possibilities. There is no need to have all of them, of course. And another thing is, these are key inclusion criteria. There are some more inclusion criteria in the study protocols I've just highlighted here, so please don't take this when you're including your patients as an inclusion criteria list. So the Wagner grade actually are these grade 1 and grade 2 that we are enrolling in our study. So there is a possibility, as we have seen from the beautiful pictures, there is no need to be completely superficial. There is a certain penetration to the tendon given, but there shouldn't be any destructions of the tendons or any joint or any bone damages or any deeper where you're tunneling, and you cannot actually measure the full circumference of the wound. When you're getting deep and you don't know where you end, those wounds are definitely not the suitable wounds for our study. So for the Armstrong classification is again the classification 1 to A, that means no infection, no ischemia, and it's also the same description as the Wagner classification. I don't know if you use it in your reports when you are describing the ulcers to refer to the Wagner or Armstrong classification. Okay, so I think for that purpose is to remember that, you know, we are taking superficial but also penetration to the deeper tissue as far as no deeper tissue is destructed. I think this is probably key. The other thing is the wound should not be infected or not a major cause based on an ischemia. These are just pictures, but I think we have seen sufficient pictures. I hope you can see that still very nicely. It is not on a nice color. So these are the key exclusion criteria. And with the exclusion criteria, even when I was preparing these slides, I was feeling, oh my God, will we ever find a patient? So I really want to challenge you, especially the dermatologists sitting here around the table. What do you think could we maybe simplify, or let us leave it as it is? So the first exclusion criteria is, I think, that has been talked through several times. If there is a deformity where you cannot offload it, those patients cannot be enrolled in the study. Why? There is at least, I think, even a class 1A recommendation for offloading wounds as a key cornerstone of wound therapy. So if we cannot ensure offloading, then those patients cannot be enrolled in the study. Further, if the wound is over a year present, there must be some underlying other causes for this wound, and we are not taking this actually challenge for APO2. This is just because we think it's, if a wound has not been closed for a year, probably there are not even any changes. This is probably a bigger challenge for our study. Ulcer bed infections, and this is actually, we defined it, the ulcer bed infection subjects requiring intravenous antibiotics or subjects requiring, ulcer bed infection or requiring intravenous antibiotics. So we left it completely up to you what you decide is an ulcer bed infection. And as you mentioned, this is a clinical judgment. Patients with an evidence of osteomyelitis, cellulitis, or even a history of osteomyelitis the previous preceding 6 months. And any other uncontrolled medical disorder, we have listed here the extremes. These are patients with uncontrolled cardiovascular or pulmonary disease, like a New York Heart Association class 4, COPD uncontrolled requiring oxygen, class 3 and 4, HbA1c above 12%, or repeated blood pressure above 180 millimeter mercury. So these are the extremes. Again, it is up to you as a principal investigator to judge if a patient is suitable for this study or not. So if I have a heart failure patient, even if I say it's a New York Heart Association class 2 to 3, but this patient has extensive leg edemas, this patient is probably not very suitable. So it's a lot also on your judgment of your patient cohort to decide which patient is suitable. This is a list of the extremes, but of course we believe that we don't want to be too restrictive on this exclusion criteria. Any severe peripheral microvascular disease, and we actually put here Raynaud's disease or vasculitis or any current diagnosis of claudication that is an evidence that there is a major ischemia present. Any other dermatologic comorbid conditions like pyoderma gangrenosum, vasculitis, systemic lupus actually, and thromboangiitis obliterans, I think we just listed here the extremes. I don't know if we should add more or if we should even take them away. Active malignancy, actually we don't want those patients to be enrolled primarily because those patients need therapy, we need anti-cancer therapy, immunosuppression, which can per se cause a lot of other comorbidities that I think we are not, those are not suitable for this study. So active malignancy, the patient should be disease-free from active malignancy for more than 1 year. Those who are less than 1 year are not supposed to be enrolled in the study, but also those patients who are receiving preventive anti-cancer treatment, and this is important, should not be enrolled in the study if they had it the previous 3 months. Pregnancy and breastfeeding should not be enrolled, but also we know that a lot of patients with wounds are patients who are often from lower socioeconomic status, so we don't want to have prisoners, incarcerated patients being enrolled in this study. And the thing is that I think this is probably the most important, considered by the investigator to have a significant disease which can impact the study and judging the patient not suitable for this study. And of course, employees at sites, spouse, anyone who is in a dependency to the principal investigator should not be enrolled in the study. We go briefly to the prohibited medications. And the prohibited medications are primarily, first of all, we don't want patients who are taking those prohibited medications at screening or who we know that they will take it during the study period to be enrolled. On the other hand, if a patient is being enrolled and has to start one of these prohibited medications, it's first of all your judgment if it's safe to continue with the treatment and the prohibited medication. We will, of course, flag a major protocol deviation, but the major protocol deviation does not mean that we exclude the patient. We want to have the follow-up of the patient, how the wound develops. This is very, very important to not having any missing data, but it is your judgment together with us together if we should discontinue the treatment or if we should continue with the APO2 treatment and the prohibited medication. So corticosteroids primarily for not deteriorating the sugar metabolism should not be taken more than 20 milligrams per week. So some low doses are allowed. I don't think we will have those patients. Intranasal or inhaled steroids are of course allowed in this study. Immunosuppressive and cytotoxic agents should not be taken the previous 30 days and during the study period. Any wound treatments with biologic treatments, we have heard there are really, there is a very thin evidence for any dermal substitutes or topical biologic therapies or other growth factors or other advanced therapies. So those patients who had been treated with these kind of therapies the previous 30 days should not be enrolled in the study. And of course, they should not have parallel treatment during the study and treatment with anti-cancer therapy. Okay. Regarding the investigational medicinal product, we are talking here about APO2. This is our IMP, the active IMP. For the main study, you will have 3 treatment doses. The treatment doses will be the 12.5 units per milliliter, 25 units, and 50 units per milliliter. We talked that we will actually enroll a parallel arm enrollment, so your patient, it could be also the first patient, could be treated with the highest dose. Actually, our preclinical studies, our studies on the named basis, have shown there is no safety issue with any of those doses. So even the first patient can have the highest dose being applied. Compared to the placebo. So what is placebo? Placebo is actually the lyophilizide that the pharmacist will prepare for the IMP. Is a cell-free culture medium that is being used as placebo. So it will look like completely like the active drug. How you're going to apply these IMP to your wounds, you will receive a manual for that, and I don't want to go too deep on that because I think there is a hands-on training required. But just for you to know, you will get from the pharmacist a syringe with 4 milliliters of a gel. These 4 milliliters have to be applied according to the measurements that you have taken with this beautiful device that Dr. Gouya will show you. And defining the square centimeters of the wound will define the volume of the gel that you're going to apply. So you will get a clear manual how to apply that, and you will get a training how to apply the IMP during the site initiation visits. So I'm not going too much deeper because it's a very hands-on training that I think it's not suitable now. But there is a manual and a training then in place. The primary endpoint, and you would think, why are they taking the primary endpoint after 4 weeks of treatment, and why don't they look for wound closure? Because wound closure is the eminent endpoint for any wound therapy clinical trial, of course. But there are several randomized controlled trials showing that there is a correlation of wound area reduction after 4 weeks and the chance to get a complete wound closure at 12 to 20 weeks. We have listed here the publications, and even the FDA is recommending for the earlier trials, look for the percentage wound reduction after 4 weeks first before you do your long-term trials. So this is actually the rationale behind the primary endpoint, and the primary endpoint is the percentage wound area reduction after 4 weeks treatment, and this is the visit 14, the end of treatment visit, which is really, really very important to have this visit completed. And what you measure there in wound size is actually the parameter that we will judge centrally again to see if there is a wound area reduction and compare that to our placebo arm, compare between the dose groups and the placebo arms. This study has primarily a dose finding, so we will not do comparisons. We have to correct for multiple comparisons. It will be an ANOVA on finding the dose group. Nevertheless, for the proof of concept, every single measurement at the end of treatment visit is really, really important. We have a number of secondary endpoints, and the reason is this is our first in human study, and we want to generate as much as possible information how to also design our confirmatory next study. So we want to know how many patients will have over 50% reduction of wound size at the treatment period. We want to have the wound size measured at every main visit. We don't take the measurements during the treatment visit as the endpoint. We want to have, of course, the patient with complete wound closure and the time to wound closure, because we believe what we can add is accelerating the time to wound closure. The recurrence during the observation period, and also we will have some additional endpoints to judge the peripheral neuropathy with very simple assessments. Dr. Alma will present those assessments. We want to evaluate also the pain structure, because what we believe actually that APO2 can induce neurological regeneration, and also with that it could be that the pain feeling will increase back again. So we have again a simple tool for assessing the pain and assessing also the quality of life. And of course, one of the endpoints is safety, any incidents of drug-related adverse events. The visit schedule, actually when I look on this visit schedule compared to many other trials, I would think it's not very complicated. It is, you need to be prepared and your staff need to be trained well for this study. But I think if everyone of the study team is prepared, the structure of performing a visit is quite, let's say, feasible for a clinical setting. So what I've highlighted is this visit 14, the end of treatment visit. I will go on a high level here on the visit structure. So we have the screening visit as the first visit. There should be a minimum of 14 days to your randomization visit, and it should not be earlier than the 14 days. I actually thought maybe we can give here some more room than 21 days. That was one of the points. Then we have, after randomization, the 4 weeks treatment period. And this is probably the most intense time, where the patient is coming every second day for change of wound dressing and application of IMP. And then we have the end of treatment visit. It's actually after completion, patient is coming back, you change the dressing, and no further IMP is being applied. The measurement of the wound here is eminent for our primary endpoint, but then those wounds who have not gained complete wound closure at this time point should be treated as your standard of care onwards. So whatever you're going to apply, that goes on concomitant medication, and it depends on your judgment. So we actually didn't restrict it, and it is up to you, but you should still adhere to the prohibited medications, like biological wound dressings, etc. Then we will see the patient every 2 weeks, and then 1 month later. And this 8 weeks follow-up is just to see how this wound is changing after the patient is off treatment. How do you get your patients? And we really want to encourage you to get back to us if you see any obstacle in finding the patients, to see if we can somehow support with the patient enrollment. I think you all have your outpatient clinics where patients are coming regularly to your clinics. This is probably the major pool. I've heard Professor Hötznegger, who will also enroll a cohort from the inpatient patient pool. You have also your database for search of chronic wounds who have been referred to the secondary care, who you might be calling back. And also, the last one is, I don't know if you have a referral network of secondary care doctors. After talking to many dermatologists that I know from friends, they are happy to send those patients to the central clinics, because those are not the most favorable patients they want to have in their secondary care, because they need a lot of time for the wound dressing. So if you think you need a referral network, we would be happy to support you with bringing the structure and see how we can incentivize the referrals for that. There are probably other ways to enroll patients, but I think from what I've heard, you have your patient pool. The only thing is, if you see any obstacles, get back to us how we can support you with flyers, information folders, etc., etc. So this is what you do during the screening visit. It looks long, but it's probably not that complicated. I have to go back. So of course we want to have the patient being informed about the study and write the informed consent. You judge on the inclusion-exclusion criteria, demographic data, physical examination, vital signs. Then relevant medical information, and this means we don't need to know if the patient had a tonsillectomy with 6 months. Relevant medical information means the ones that are ongoing or any relevance during the past 6 months. The same goes to the surgical history, and what is actually should be extensive is wound assessment. So we want a lot about the history of the wound, how long is the wound present there, how does it look like currently, what was the previous treatment of the wound. Then you assess if there is adequate arterial perfusion in looking if the IBI, toe pressure, etc. is present, otherwise you have to refer them. Assess concomitant medication and current standard wound care. Patients should be offloading. If not, then you have to ensure that the patient will get offloading. This is very important also for the observation period, to see that the wound is not getting closed and during the offloading, new offloading. Laboratory assessments you have to perform, actually primarily safety parameters. It's in hematology, serum chemistry, it's nothing fancy that we would expect you from the local labs. Urine dipsticks also for urine pregnancy in female with childbearing potential. You measure the wound and take a picture. You give them the VAS score, to explain them how to actually assess the VAS score, because the VAS has to be filled in at every visit. It's a vertical line. Dr. Wilm will go on that. The patient will get a quality of life questionnaire, which is not that complicated. We will listen about that, how that is being structured. And you put a wound dressing according to the standard of care at screening. And this is very important, that you continue with the standard of care and at this screening visit. And you schedule the next week's minimum 14 days apart. So I think when I went through that, I think you need to at least have a 1 to 1.5 hour time scheduled for the patient during the screening visit. I'm not going in that detail to all the visits, but I just want to highlight the important parts at each visit now. So at the visit 2, it's a randomization visit. Here you decide if the patient is suitable to be enrolled in your study, and the suitable fact is actually on the wound measurement. So we've heard about these inclusion criteria, that there shouldn't be any more change than 30% compared to the screening visit on the wound size. So this actually confirms you the last bit of your inclusion-exclusion criteria to judge if the patient is suitable for your study. Maybe the patient is already trained and put the vertical line on your VUS and quality of life questionnaire, but with the first assessments, you judge if the patient is suitable, and then it comes that you apply the IMP on your wound. Now, it could be that the patient comes to your clinic in the afternoon and you don't have the IMP available because you didn't even know if the patient is going to be suitable. So what to do? We added in the protocol that it can be performed 2 days apart. So you can, okay, you're suitable, come back tomorrow or come back in 2 days. Then you inform the pharmacy, we have a patient, is coming then and then, the randomization process and the IMP preparation starts. So during the treatment period, actually, the assessments are very simple. It looks long, but it's actually, if you just say, did you have any adverse events, any new medications, the patient put the vertical sign on the pain assessment, you look on the wound and you just assess wound infected or not, odor, color, dolor, erythema. You apply the wound and you put the dressing. It's we will talk about the bandage or the dressing, how you apply it on the IMP, and schedule the next visit. So between visit 2 and 13, I believe if your study team is being trained on these assessments, you would not need more than half an hour. This is a maximum that you actually would need for these treatments. The only key factor is that the pharmacist should have prepared the IMP on time, so you're not waiting, or patient is not waiting for the medication. End of treatment visit is, again, I want to raise it, it's a very, very important visit to us because we are generating the primary endpoint. You take here the, again, the wound measurement, the photography of the wound, and this data is defining if we were successful with APO2 or not. The other assessments, what will be added here is the quality of life questionnaire and the neurological assessment that we will listen about that. Then we have two weeks after, visit 15 and visit 16, further 2 weeks after, the same visits off treatment. And it's important, after end of treatment visit, you continue with the standard of care wound treatment. During these 2 visits, it's actually observational. You collect if there are any new happenings on adverse events or CONMEDs. You clean the wound with standard of care. You take a picture with the wound wound measurement device, and schedule the next visit. And this is the last visit, this is visit 17. It's again a little bit more thorough because you have some laboratory workup. You have again physical examination, CONMED, the neurological assessment, quality of life, pain scale, and wound assessment, and of course you take the picture. And then after that you tell your patient, thank you for being in our study. The patients will get some support for their time they're spending in this study because it's intensive. So we believe 30 euros per visit is okay. Even they can even take a taxi to come to the visits. So they are getting supported to adhere to this quite intense visit schedule. So I have just one last slide, and probably it's just a praying and preaching slide at the end of the protocol. we should avoid missing data. During the past years, many trials have been rejected or not being judged by the authorities because of missing data. We had big trials like the Trilogy trial, etc., where the patient follow-up was just missing. So it is really eminent that we keep patients in the study. If we are taking them off treatment, we should even ensure that the patient get the end of treatment visit, the visit 14 completed. You should take all efforts. I know sometimes patients are stubborn, sitting there, I don't want to come back or whatever. We should get the maximum information possible. So for me, actually, the wording dropout doesn't exist. We have missing data if a patient dies, if a patient is permanently lost to follow-up, meaning that you have tried your best calling his home physician or him at home, he moved away, he moved to Alaska or something, so we have a permanent loss to follow up. He, by purpose, withdraw consent. In that case, we cannot do anything, so he didn't want to be part of this study anymore. Otherwise, we shouldn't have any missing data from any patient. This is really eminent. I just want to give it to you. We try our best for patient retention with the vouchers incentivizing. If you feel there is a risk, we are here to support the sites for keeping all the patients' data in. Our aim is 100% data in the study protocol. Thank you.